need to think. We need to look into the considerations that we need to think and do for these deep cavities. Okay, this is a very important chapter topic for both resto and operative. Okay, so we will discuss that, but before that I would just like to request you one thing. Like, I have seen my video statistics that many people are watching the videos, but if I could just request you all just to like, share and subscribe, because it is completely free, but it just gives me confidence and a courage that I should spare some time and just to continue uploading the videos, because last time as well I stopped because there was no response, so I thought that maybe like this is a waste of time, so that's why I stopped posting any videos. But if you can just give me like, if you can just share my video so that many people can watch it, and this will just give me something in return. um yeah, so okay, so we will discuss this topic, which is a deep carious lesion. How will you deal with the deep cavitated carious lesion in a permanent maxillary molar tooth? Okay, so this is a complaint which is from 30-year-old patient. She complained about severe attacks of pain. Okay, each of a few second duration and fading slowly, but she cannot identify which tooth is responsible. So now you just, even if patient is saying these things, you should make a picture in your mind, like which should what is my diagnosis, right? Provisional diagnosis: hot, cold, or sweet food and cold air on the upper right jaw makes the pain worse. So this, he or she is experiencing severe attacks of pain which is only lasting for few seconds, and she is also having hot, cold, and sweet food stimulus, right? So the pain has been present intermittently for several months but has only recently become worse, and there is no pain on biting. It means the periapical region is still sound and healthy. The pain is only from the tooth. That's why she's not able to pinpoint the tooth. Okay, because in the reversible pulpitis, the pain, it is very difficult for the patient to localize the tooth. The patient attends on a casual basis for dental treatment, despite the fact that this carious lesion is very large. Perhaps surprisingly, it is the only lesion in an otherwise intact arch, and there have been no other lesion noted in the last 3 years. The patient is therefore classified as a low risk because he or she only has one carious lesion, so that's why he is in low risk. Patient is fit and healthy. Extraoral reveals no abnormality, and intraoral there is no tenderness or swelling around the buccal. So it means the problem is only going on inside the tooth. The surrounding soft tissue and even the periapical tissues are healthy. The maxillary right second molar is shown in the figure. What do you see and how do you assess the problem so far? The classic history of acute pulpitis and repeated attacks of pain, as opposed to continuous severe pain, probably indicates that the pulp can be preserved. So, this is a sign of reversible pulpitis in which the pain comes and goes. If the pain is continuous and severe, it is more likely irreversible pulpitis. The fact that there is no pain on biting and no tenderness over the root suggests that reversible pulpitis and helps exclude periapical periodontitis. So, if there is no pain while patient bites and there is no tenderness around that area, it means periapical tissues are healthy. There is a deep cavitated lesion on the occlusal surface with extensive exposed carious dentine. Opaque white demineralization of the marginal unsupported enamel indicate that it is demineralized despite not having fracture off during function. The slight darker appearance of the tooth distally suggests that caries undermines enamel somewhat distally, and that it possibly involves the dentine supporting enamel of the mesial proximal surface. So we can see like this is the hole, and we can also see some demineralization spots, which are these white colored spots, and also we can see some shadow here. It means that there might be some hole which is developing, which is in the dentine. This is a relatively small upper second molar. Females have slightly smaller teeth, and when second molars are this small, the third molar may not have developed. This may influence the decision to restore or extract some. So sometimes if the patient is having problem in the second molar and they do have a third molar, sometimes we may think like, if the third molar hasn't erupted yet, some we think that maybe we can take out, we can extract the second molar, and the third molar can start to come in this position, right? But like looking at the smaller structure, it may be a possibility that the third molar is not present at all. So we just need to think about it, whether we need to extract the tooth or to restore it. But what investigation should we carry out? First of all, we need to find out if the tooth is vital or not, which is called tooth sensibility test. Okay, even though the symptoms suggest a vital pulp, but this is a very large cavity in a molar, and partial pulp sensibility is a distinct possibility. Radiography is required for a variety of reasons. So, test of vitality, which is a cold test, and the X-ray is required. The proximity of the lesion to the pulp and its lateral extension, undermining cusps, and the proximal enamel will all affect the overall restorability of the tooth. Pulp size reduction by tertiary reactionary dentine will also be visible. So it is very important to find out how deep the hole is, how proximal it is for the pulp, what is the pulp size, if there is any production of tertiary dentine or not, and depending on the chronic nature of the caries process in this tooth. It may also be possible to see evidence of periapical periodontitis, which is like there might be some evidence suggest that there might be something going on in the periapical region, which is the inflammation of the periodontal structures, which include widening of periodontal ligaments and loss of lamina dura. The ideal view would be a periapical or a bite wing radiograph, depending on your suspicion about pulp sensibility or caries in other teeth. If symptoms were of an irreversible chronic pulpitis and there was potential indication for root canal therapy, CBCT could also be considered. So this is like CBCT is like three-dimensional view, and it gives us better understanding like what is like it gives us 3D picture of the tooth and gives us better view that we can see. And generally the CBCT is done by the specialist because they are more able to read or interpret the CBCT. Okay, the imaging modality would give a much clearer indications of periapical pathological and anatomical changes with regards to radiolucencies, bone resorption, proximity to the sinus floor, and the root canal apices that might be affected. So CBCT gives us the best view because it is three-dimensional. When you perform these investigations, the tooth respond quickly and strongly to cold test, indicating a hypersensitive pulp. Although the proximity of the pulp to the cavity may also contribute to this strong response. Okay, so with the cold test, the tooth responded hypersensitive. The radiography shown, what do you see? The coronal radiolucency indicate that the carious lesion is extensive. It reaches the inner third of the dentine close to the pulp. So this is the outer third of the dentine, this is the middle third, and this is the inner third. So we can see that it is reaching the inner third of the dentine and closer to the pulp. There appears to be a bridge of intact dentine between the lesion and the pulp chamber. Caries has undermined most of the occlusal enamel and also the distal enamel, but there are no separate proximal lesions or cavities. So there is only one cavity, but it is very big in size. The coronal pulp chamber is rounded and reduced in size, with the pulp horn obliterated by reactionary dentine. So this, from here we can see, like, due to the response of this hole or the bacteria, there is a deposition of tertiary dentine which made the crown pulp horn rounded in shape. There is a slight radicular cervical burnout of the dentine immediately above and below the mesial and distal of amelodentinal junction. This could be mistaken for caries extending to the crown and distal root. Okay, so there are some cervical burnouts which we can see like this, and these are not caries, but this is just a like defects. But the shape and the site of the relative radiolucency do not suggest caries because it is under the gums. If other radiographs are taken, such as bite wings, often the cervical burnouts can be observed on other teeth in a similar anatomical location. Of course, finding of radiography must be reconfirmed by further. So you should not only rely on X-rays, because X-rays, they do not see like the clear image, they do vary. So we need to reconfirm it by looking again into the mouth, by like we need to confirm it by checking both the clinical and the radiography. So what is your diagnosis now? It is a acute pulpitis in the maxillary second molar, which is caused by extensive occlusal caries. The pulp appears vital, and there is no evidence of periapical periodontitis. Okay, so is this tooth restorable? Of course. So if the pulp is not yet involved, so the filling is the only thing that we can do. The prognosis may be guarded because this is a very big hole, it is closer to the pulp. We cannot say that prognosis will be good or bad. It is like it will depend, because the pulp may still lose sensibility over time as a result of either the caries process or restoration placement. There is no indication for immediate there is at this position there is no indication that we just start with the root canal treatment, because the pulp is healthy. So we should just put a filling there, make patient aware, and just put a watch, and we'll see in future how you go. There is also sufficient supragingival tooth tissue available to support the restoration as well. Restorability of the tooth is also available. So, what will you do first? The patient is in pain, so the immediate management response must be to relieve it. Pulpitis does not respond to analgesic drugs, and the appropriate treatment is suitable. Caries excavation and then restoration. If a definitive restoration cannot be placed immediately, a provisional dressing could be placed following the selective excavation of caries tissue. This would help relieve pain by removing the stimulus, which is bacterial products and acid penetrating drainage. So you just need to clean that area and put something there. If you cannot put a permanent dressing, just put a provisional dressing. And by insulating the inflamed pulp from any triggering stimulus. Eugenol containing temporary restorative materials have an attendant effect on the pulp, thus reducing the pain. However, it must be noted that eugenol containing materials must not be used if the definitive restoration to be placed is an adhesive resin composite, as the eugenol affects adversely the bond resin polymerization process. So in this era, we just use the composite, which is very common to be used as a restoration. So if you are using the composite, you cannot use the eugenol containing restorative material because they do have some interaction. A second alternative might be just to place the filling straight away. You should not put a temporary dressing and wait. Just put a filling, which is the longer term provisional restoration with indirect therapeutic pulp protection, such as you can just put a layer of pulp protection there, and on top of that you just put a composite as required in an attempt to induce further reactionary dentine formation in the pulp. However, the caries lesion does not appear to be in imminent danger of breaching the pulp. Indeed, a growing body of evidence argues that indirect pulp protection is not necessary or beneficial because many of the modern adhesive biointeractive materials exhibits the desired properties of pulp protection material. Okay, so the carious lesion does not appear to be in imminent because there is a bridge of dentine which is present, and a growing body of evidence this says that indirect pulp protection is not necessary. They say that there is no need to protect them, to put any additional material there. You can just put the composite straight away, because these modern adhesive biointeractive materials exhibit the desired property. They do have the property of pulp protection in themselves as well. Removal of caries will leave a weakened crown, more susceptible to fracture under normal occlusal loading, and immediate definitive restoration is the best course of action. Subsequently, the patient needs a full caries risk susceptibility assessment and an intensive preventive regime that may include topical fluorides. So why not to extract? Such a large lesion is in a casual dental practice might well lead to extraction if that patient wishes. If patient wants this tooth to be out, we just need to take it out because we cannot force patient. We can just explain them, and but we should not force them. But in this case, she is a young patient and she may not have a third molar. So, if present, it may not erupt spontaneously after the extraction. So, even though the prognosis may be guarded, there is a good chance that the tooth can survive for some years. So, this is a like better option that we can just put a filling now and wait rather than taking the tooth out. So, what is minimally invasive operative treatment? How will you provide analgesia? So, for the analgesia, as this is an upper tooth, so we just give the infiltration, which is for the filling, we do not need palatal restoration. We can just do the buccal infiltration. Okay, of local anesthetics, and there is no continuous pulpal pain so to suggest. And if this fails, palatal infiltration can be used. Is a rubber dam essential? Yes, because this is a very big hole and it is closer to the pulp, so it is very important that we isolate the tooth properly. There is a risk of pulp exposure, so it is very important that we use it. And how do you gain access to the lesion? So there are different ways that we can use. First of all, you can use the burrs, which is mechanical and rotary, or you can use the hand excavators such as spoon excavators, or and these days you can also use something called as air abrasion, ultrasonics, okay, and lasers. So these are some new techniques that you can use, but more commonly in clinics we use burrs and hand excavators. How should you remove the caries dentine? Conventionally, the caries dentine is removed with the large, slowly revolving rose head carbon steel burr and hand excavator. Possible alternative techniques are shown in table 9. Yep, so these are the techniques that you can use. No method is completely guaranteed to remove the necessary amount of caries dentine. The best method are those that gives you more tactile feedback, because every time you are removing the caries, you need to check with your explorer to find out if the area is soft or hard. Okay, because if it is soft, then there is caries, but if it is hard and scratchy, it means that the caries is gone now. The best method are those that gives you more tactile feedback to the operator, because assessment of tissue softening and texture is critical to remove the optical amount of dentine. These includes the mechanical and the chemomechanical methods. Okay, so mechanical means with the explorer, and chemomechanical means the dyes that are available. How much caries dentine needs to be removed? The correct amount to remove is the minimum required to restore the tooth successfully. All allow the dentine pulp complex to stimulate healing and prevent further disease progression. To achieve this, it is necessary to understand the structure of different parts of a carious lesion. There is a continuous histological spectrum of degree of dentine deduction in caries at the advancing front. At the depth of the lesion closing to the pulp, there is demineralization. Okay, and remineralization during reversal. So there are different zones of the dentine. So there is demineralizing zone and the remineralizing zone. Okay, so these are different layers. So these are more like histological layer. This is not important as of exam point of view, but just for your knowledge, like the dentine which is superficial, which is closest to the enamel, would be infected. Infected means if there are bacteria in them, that is the infected layer. Okay, and the affected layer is which in which there are no bacteria, but there are some toxins or the effects of the bacteria are still present. Okay, so this is the affected dentine, which is demineralization, and it is closest to the pulp. Okay, so between these layers, so I do not recommend reading this histology because I don't think it's important as of exam point of view. How can you recognize this excavation endpoint? So how do you recognize that? Yeah, so this is the point where you have to stop. This is difficult to do with clinical accuracy. The relatively smooth line making the edges of the Jones in 9.4. So this is the Jones of caries dentine and pulp dentine defense reactions. So left panel is zone of caries. So zone of caries is A, which is the contaminated region. Uh, Contaminated infected dentine, including the zone of dentine destruction and bacterial penetration along intact tubules. B is the affected. So bacteria are not in this region, but there are some toxins that has reached this region. So this is B region, which is the affected dentine. Right panel, the pulp defense reaction. So C is the translucent zone formed by peritubular sclerosis around the lesion. So this is the boundary. C is the boundary. Regular or irregular reactionary tertiary dentine that has reduced the size of the pulp. So this is the D is the our pulp response. D and E is the pulp response. Okay, so this is the john and this is the bacteria, so we need to remove the caries from until this position. Okay, so the relatively smooth lines making the edge of the zones in figure 9.4 do not reflect the irregularly shaped advancing front and the small tongues of bacteria that penetrate tubules in advance of the main lesion. Again, it must be emphasized that these zones are not histologically distinct but blend into each other. So they are not completely distinct that you should know, like you just have to stop at that point. You just have to work more like your clinical judgment. It is accepted universally that not all bacteria have to be removed during excavation. Those that are sealed from the oral environment, the primary source of their substrate, will either die or become dormant. Provided the restoration provides a good seal, the retained bacteria will not be sufficient to allow the caries process to progress below the restoration. So it is just like IPC. So they say that even if there is some amount of bacteria that has left behind, so if you seal this zone completely, they would die because they would not have any food or nutrition. They would die. Okay, but excavation of grossly contaminated, but there should be no you should always remove all the part of infected dentine, okay, which is all superficial, very soft and wet, often more darkly stained. Dentine is highly contaminated and is readily removed. Whether the underlying demineralized caries affected dentine, which can potentially be repaired by the dentine pulp complex, may be spared in is a decision that must be made on a case to case basis. So for the infected dentine, you just have to take it out. There is no doubt about that, which will be soft and wet dentine. Okay, but the dentine which is the demineralizing dentine, you can think about the cases and you can just leave some part of it, but it will depend on case to case basis. It is usually preserved in the cavity depths to protect the pulp, but cleared from around the enamel dentine junction to ensure that the peripheral seal is most effective. Demineralized dentine is often stained and is softer than the surrounding healthy dentine, a possible clinical indicator that the boundary zone between the infected and affected dentine that has been reached is that the cavity surface is both scratchy and sticky to a sharp dental probe, sometimes called leathery. So demineralized, so the infected dentine will be soft and wet and highly stained. And the affected dentine, which is the demineralized dentine, will be scratchy and sticky, which sometimes also termed as leathery. Unfortunately, this sensation cannot be appreciated in the words from a textbook and requires first-hand experience of the sensation. Can caries detector dyes help identifying the zones? So there are some dyes that has been developed in 1970s, and based on their properties of propylene glycol solutions, they claim that it stains the collagen that has become denatured by the caries process. So, however, they tend to penetrate too far into porous dentine and stain as it denaturated collagen as well, thus staining both infected and affected zones and even sound dentine as well. So, removing all dyed stained dentine therefore risks excessive and unnecessary dentine removal. So, there are some dyes that have been developed in the past. So those are called caries detector dyes. So previously it was mentioned that it is really a good idea to use them and they just help in deciding the zone that you need to remove. But later on studies found out that this these dyes they do not only affect the show the infected dentine, but also the affected and sometimes the normal dentine as well, which is the over treatment, right? So it is not very conclusive to use them. So new caries indicators that are still being developed detect bacterial metabolism and have the potential to identify the contaminator, which is the infected zone, more accurately in future. The appearance after initial caries removal is shown. What do you see? So this is the thing that you can see. So what we can see is that the dentine surface is still friable and flakes parallel with the surface along clefts that are the result of bacteria by breaking out of the tubules. The base of the cavity must still be in the contaminated or infected zone. It is just start to feeling scratchy. So as I was mentioning before, so whenever we remove the caries, we always check with the probe or the explorer just to see how what's the texture of the surface. Okay, so it has just start to become scratchy, which is like there is still some amount of infected dentine present, but we are going there. The final extent of excavation is shown here. So, further dentine has been removed around the cavity periphery. Affected dentine over the pulp has been retained. It does not show the gross flaking seen in above figure, but is still stained, but dry and appearing matte. So, this one looks more wet and darkly stained. This one look bit lighter and also more leathery and scratchy. Consideration must be given to the relative hardness of the dentine retained at the base of the final cavity. If it is too soft, there is a risk that cohesive failure could occur within the dentine itself on shrinkage of an adhesive restorative material. This decision must be also take into account relative pulp proximity. Okay, then unnecessary exposure of still vital pulp will significantly reduce the success of the medium or long term success of maintaining pulp sensibility and should be avoided. So we just have to on the basis of case to case, we just have to decide whether we need to go more deeper, or we can just seal this area by putting some calcium hydroxide layer there and putting a filling on top of that. We just need to decide case to case. Should the restoration have a mesial box? The junction is visible and both mesial and distal enamel have lost all or most of their support. There is an argument that the unsupported enamel will fracture, leading to failure of the restoration. If amalgam were being used, then both mesial and distal boxes would definitely be required. Conversely, removing the mesial and distal enamel would seriously compromise the strength of the cavity, particularly buccally, and modern adhesive material have good compressive strength and adhesion to the whole of the dentine and enamel inner surface of the cavity and will provide some support for enamel. It must be accepted that leaving this enamel does incur a small risk of failure, but the potential benefit is always more. So, whenever we decide anything, we just work on risk or benefit analysis. And in this case, they question like whether we need to make the boxes here. So, if we will be using the amalgam, then definitely we would have to make the boxes here just for the better adaptability of the amalgam. But for the composite, we think like it will be over treatment because there is some amount of surface which are present, and the composite they have like good compressive strength. If we just put the filling here, I it can give the good prognosis. Okay, then surely caries have been left under this restoration and it will fail. In the past, the cavity preparation would have been considered inadequate because in the past we just have to clean all the dentine. We cannot leave the affected dentine behind. Okay, with soft and stained dentine remaining on the cavity floor. There are currently bacteria remaining in the dentine. If this cavity were to be restored with the modern high copper alloy amalgam with its inert poor marginal seal, then the restoration might fail. However, the principle of caries dentine removal have been revolutionized and partially by the advent of adhesive biointeractive restorations which seal effectively. So the composite they seal very effectively and partially by recognition that caries dentine can remineralize. So the affected dentine can remineralize. So we can just leave it. There is a risk that this more conservative minimal invasive approach will lead to failure if the quality of the overlying restoration is suboptimal. So leaving more carious tissue that was accepted in the past does carry a risk, but the affected dentine has been left behind for specific justifiable reasons. This MI approach will require continued monitoring for success, and as with all operative dentistry, good patient behavior adherence to oral hygiene. So if we are leaving the some affected dentine behind, then we need to make sure that we explain it to the patient as well, that if we just try to remove more dentine, then it there is a risk that we can expose the pulp, and then the only treatment we will left with is either to take the tooth out or take the nerve off the tooth out. Okay, but if we are doing this, then for in our considerations we need to put a filling which has a good marginal seal, and in the patient's hand it is just to make them aware that they need to follow good oral hygiene just to maintain a good environment. Annual review will permit any visual changes, and in their following visit, we need to keep an eye on this filling just to see how they are going with that. Early in its life, the restoration may develop some staining along sections of the margin, but this does not constitute failure of the seal. However, if staining is accompanied by roughness or gap formation detectable with the ball-ended dental explorer, this might indicate the seal has been breached and the restoration would require repair. Depending on the extent of the breakdown, the ultimate success of the MI operative management protocol is dependent on case selection, appropriate selective caries removal protocol. Okay, so what is stepwise excavation? So this is a technique in which carious tissue is removed in increments to allow the dentine pulp complex to heal the deeper layer of the caries affected dentine, and superficially infected dentine is removed and so the stepwise excavation is just that. So if there is any hole and it is a big deep hole, so in that, what they do is they just remove the superficially infected dentine and put there a temporary restoration, okay, just to cover the seal of the restoration. And the affected dentine, with the time, it just start to remineralize and become healthy, and then again after over a period of some months they again go back and they drill the tooth and they see like how the dentine is doing, and if it is healing then they just put a restoration on top of that. But that is not really required these days. We If there is a good seal of composite, we can just do the permanent restoration straight away. Okay. So does the cavity require a lining for pulp protection? Yes. So there are different purposes of the liners, that is to protect the pulp from the bacterial infection and diffusion of bacterial acids, and to seal, impregnate, and mechanically reinforce any layer of caries affected dentine. Also to stimulate the dentine pulp complex. So basically the liner is just like a layer on top of the pulp that helps in pulp repair, and it also protect it from the bacterial infection, toxins, and thermal, electrical, and mechanical stimuluses. So many adhesive restorative materials and adhesive carry out all these function, and so the value of separate liner is nowadays debatable. Okay, so what materials could you use to restore this tooth? First of all is the resin composite, then the glass ionomer. So resin composite is a good thing that it will give the good appearance. It has a good mechanical properties and intact enamel margin as well. Glass ionomer cements, those are bit weaker cements. Okay, it's easier to place the filling, but they those are not very strong cements. Okay, so for the adhesive layer restoration, which is the sandwich technique, most in which first we put the GIC and on top of that we put the composite. Most useful for very deep cavities with margins primarily in dentine. Good mechanical properties with GIC as dentine replacement, composite replacing enamel, good appearance and long lasting, no base or pulp protection. So we can do this. Okay, we can just put for the deep cavities, we can just put a glass ionomer cement or glass ionomer liner, just like, or base, which is like vitro bond, and on top of that we can just put the composite. But it is very technique sensitive because there are two choices of material, and we are also doing like so many things. And the amalgam, there is an option, but it is just like these days we do not really use amalgam. Okay, so what is the most appropriate choice for this cavity? So there is no absolute correct answer. In this case, the decision was made to use resin composite, would adhere well to the extensive supragingival enamel margin in its supporting the surrounding tooth structure because of its adhesive and mechanical properties. One disadvantages of the resin composite is the need to place the restoration in small increments to reduce shrinkage stress on the cavity margin. So, composite should only be placed in very small increments. This is especially important in this case where there is considerable poorly supported enamel, but can be overcome by using the latest low shrink bulk filled resin composite materials. Okay. So, are there any medical legal considerations? So, it is very important that we provide a good quality and good care. Patients should be included in the decision making journey with all the options. So, whenever we describe to the patient, um, and this will also help you in your part 2 OSCEs as well. So we should always give them all the options that are available, including no treatment option as well, and also the material that we are going to use, what are the risks and benefits of the material. And also it is very important just to take some intraoral pictures, x-rays, just to record everything, because this was a very big hole. And if you have documented it in your notes that this was a big hole, and I have explained what could have happened, and we have also left some demineralized or demineralized dentine behind, and on top of that we use this material, so this could really save you in the future if there is any problem develops. Okay, so this was it, and I hope that you liked it and this will help you, and thank you so much for watching my videos. Thank you.